Greetings again, everybody. We're going to talk here about some of the less common causes of postoperative fever, nevertheless very important to know both for clinical practice and steps 2 and 3. I highly suggest, if you haven't watched the other 4 slides reviews on postoperative fever, that you go back and watch those, because this is going to kind of assume that you know about those. So postoperative fever can be classified into this mnemonic as wind, water, walking, wound, and wonder drugs. And we're going to talk about the wonder and drug causes of postoperative fever here. The wind, water, walking, and wound kind of fall into this nice timeline. It's not rigid, so you can't exclude it if it falls out of it, but it tends to occur within this timeline. So atelectasis and pneumonia tend to be the first things that can come up. UTI can follow that, particularly if the patient has an indwelling catheter. Walking would be DVT, pulmonary embolism, thrombophlebitis. That tends to occur roughly day 4 to day 8, especially in immobile patients. And then wound infections occur day 5 to day 7 and thereafter. What we're going to talk about here can occur anytime. Some of these things we're going to talk about can occur actually during the surgery and do occur during the surgery, and some of them can occur way down the road depending on what drugs the patients are on or the nature of the surgery. So really, this does not occur into a timeline, unlike the other 4. So we're going to first talk about drug fevers, particularly malignant hyperthermia, which is the biggest one that you need to know about, and it's a deadly possibility, so that's why you need to know about it, especially if you're planning on going into anesthesiology. This is something that's going to be central to your career. Other potential causes of the wonder and drug postoperative fevers include transfusion reaction, which you can kind of consider a blood transfusion as a drug of sorts. Neuroleptic malignant syndrome, which is a cause of postoperative fever. We're not going to talk about it here, though, because I address it in the psychiatry lectures. And then some of the less common causes, which are more so due to the patient's factors and the specific surgery that the patient had. I'll also go over some clinical strategies that are useful in investigating what the possible cause is of postoperative fever, and then I'll show you a couple articles that I found to be interesting. So this is a more comprehensive view of postoperative fever. We're going to primarily be focusing on causes that occur within the first 24 hours, because the drug fevers and some of the wonder causes tend to occur within the first 24 hours, but not all of them. Now, if you are keen on your surgery knowledge, you should know that the number 1 cause of fever within the first 24 hours by far is trauma and cytokine release. Now, I say cytokine release because when I'm saying trauma here, I'm not referring to trauma like you got into a car accident and now you need surgery. I'm referring to the fact that surgery itself, cutting somebody open and manipulating their organs, their bones, their muscles, is a trauma. So it's going to result in cytokine release, a lot of cytokine release, and that can cause fever, and it in fact does in a lot of patients. So that is the most common cause of postoperative fever, and it occurs within the first 24 hours. Other causes within the first 24 hours include drug reactions, depending on the drugs that they're on, any kind of infection they may have had prior to surgery, or that they may have got due to the injury that required them to get surgery, medications, transfusion reactions, the all-important malignant hyperthermia, neuroleptic malignant syndrome, necrotizing fasciitis, and adrenal insufficiency. The 24 hours to 7-day period is sort of those wind, water, walking, and wound mnemonic. So that's going to be the surgical site infection, which I believe to be is the number 1 cause of fever in this period. Drug reactions, pneumonia, urinary tract infections, DVT, pulmonary embolism, thrombophlebitis, that's all within that mnemonic. Reaction to installed hardware, this is going to depend on the surgery that the patient had, and then IV catheter related infection. And I'm just going to give you fair warning here. I just heard my dog growling, so if he barks, I apologize. Okay, the 7-day to 1 month period, which is generally after the patient's been discharged. Subacutely, the patient, again, can get surgical site infections. Usually we see them as abscesses. They can also have drug reactions during this period, depending on what drug they're on. Thrombophlebitis, DVT, pulmonary embolism, they're all possibilities, depending usually when the patient is, if they're immobile. And then, very importantly, C. diff diarrhea, especially if they're on antibiotics. And then some of these surgery and patient-specific factors I'll mention at the end. So drug fever is not a diagnosis. It's an umbrella term, so never write this on a patient's chart. It will look very unprofessional. Drug fever is just an umbrella term, and it's related. It's a diagnosis. It's a reference to the fact that the patient has a fever, and it's likely attributed to a specific drug. So what we're talking about here is fevers relating to drugs, and it ranges from life-threatening to really, really benign. So the life-threatening is malignant hyperthermia, and you need to know about this for step 2 and 3 and for clinical practice, because this is very, very important. Like I said, if you're going to be an anesthesiologist, this is going to be central to your career. This is the most serious drug fever, and it is a reaction to anesthetic agents, particularly the neuromuscular inhibitors. Where we see this the most is succinylcholine. It can also be seen with halothane, which we don't really use in the U.S., but if you're going abroad doing mission work, you may use halothane. We do however, see it with seroflurane, which is commonly used, especially in pediatric surgery, and then desflurane. Anything that ends with flurane, F-L-U-R-A-N-E, can cause malignant hyperthermia. Genetics are implicated, and so it's important to get a pre-surgical history. Obviously, if a patient is coming in for surgery and they have had malignant hyperthermia before, you want to know that, because you're not going to use certain drugs. Even if they have a family history of malignant hyperthermia, that is something that's very important to know, because it's going to impact the anesthesiologist's decision. I don't expect you to have to choose an anesthetic on the USMLE. This malignant hyperthermia usually develops during surgery, but it can develop up to 10 hours after administration. And I do believe that I've seen in an article that if fever develops 16 hours after surgery or more, you can effectively rule out malignant hyperthermia. But usually it develops during surgery, and I would expect on the USMLE that if you're given a question, when you're given a question on malignant hyperthermia, it's going to be in the setting of a patient who is presently being operated on. The symptoms, well, of course, fever, but particularly a very high fever and an elevating fever. So it's going to continue to go up, 101, 102, 103. So an accelerating fever, rigidity, tachycardia, tachypnea, and then there are other signs. But these are the things that you're going to notice as the surgeon, as the anesthesiologist. You're going to note the rigidity and especially the tachycardia and tachypnea. And what this is it's just this hypermetabolic state that's brought upon by the anesthetic. The diagnosis is clinical. Obviously, if you're in surgery, you're not going to have time to run labs. This is something that is an emergency, so you need to make this diagnosis clinically. And what you're going to do, treatment, and this is very important to know, all you need to do is commit this to memory: immediate administration of dantrolene. That's what you do for malignant hyperthermia. Any delay reduces survival, so that's why we're not doing any kinds of labs. And of course, operation should be aborted because you're going to stop the administration of whatever the anesthetic agent is. So the operation should be aborted, and dantrolene will be administered. Dantrolene should be administered immediately. Some other drugs that are commonly implicated with postoperative fever, this isn't all of them, but these are the most common ones. If you know other ones, which I'm sure you could find more online, you can feel free to comment and write them down. But these are the most common ones that I've seen come up in the USMLE. And also, they're very common for patients to be on these drugs anyway. So beta-lactam antibiotics, including imipenem and meropenem. Sulfonamides, lots of patients on hydrochlorothiazide, which is used for congestive heart failure, etc. Trimethoprim sulfamethoxazole, which is an antibiotic. Phenytoin, which is an antiepileptic. Heparin, lots of patients on heparin. Indomethacin, which is an NSAID. Symptoms of these other drug fevers are going to include, obviously, fever, and rash and eosinophilia are also things that you can see. So fever and a rash in a patient who's getting a drug after surgery, probably due to that drug. These are the ones I would commit to memory, these classes and drugs, as far as being associated with drug fever, but there are a lot of them that can cause drug fevers. Usually with the drug fevers, it includes a rash and eosinophilia. The treatment, it's not really a treatment, but you're just going to discontinue that particular drug and replace it if possible. These are generally not life-threatening problems, but they're something that you want to address. All right, transfusion reactions. So this is an immune reaction, as you probably know, to incompatible blood products. This doesn't really happen anymore. I mean, it does, but it shouldn't. Because we do cross-typing and we make sure we know the patient's blood type before we administer blood products to them. However, confusion does happen. If somebody reads the blood type incorrectly and enters it into the computers, if they deliver the wrong bag of blood to the wrong patient's room, all of those things can happen. So usually it's clerical errors. This shouldn't happen if you and the lab staff are doing your job properly. But it does happen, so we need to keep this in mind. History, well, this is going to be a patient with a transfusion. They have to have gotten a transfusion to get a transfusion reaction. Symptoms are going to tend to begin at the time of transfusion, and as you continue to transfuse them, the symptoms are just going to get worse and worse. So a fever will start. Red-colored urine, so check your Foley bag if you have a Foley catheter attached to them, which usually you do. Tachycardia, wheezing, rash, and hypotension. And I italicize hypotension here because this is obviously a life-threatening manifestation. The diagnosis is clinical. I would focus here primarily on the red-colored urine. That's going to kind of be the dead giveaway. But fever, anytime you have fever during surgery and tachycardia, you should be thinking either of malignant hyperthermia or transfusion reaction. Definitely transfusion reaction is higher up on our differential if they're getting a transfusion. But it's a clinical diagnosis. So treatment immediately, you're going to want to stop the transfusion, but keep the fluids on. So don't stop transfusing everything. Keep the fluids on and continue giving them normal saline or Ringer's lactate. And if you're not giving them normal saline or Ringer's lactate, you probably should start to decrease the likelihood of hypertension. Once the patient has had the transfusion reaction and they're after the surgery or in the days after the transfusion reaction, you should keep an eye on their labs because DIC can develop after the transfusion reaction. And of course, you should investigate what went wrong clerically because I guarantee you the patient, if they find out about this, will sue you or the hospital. So. All right, other causes of postoperative fever, and these are the things that really depend on the surgery, the surgical area, the patient. It's not just generalized due to any surgery. So if a patient had abdominal surgery, they can develop pancreatitis. If they're having their bowels or their intestines manipulated, there can be perforation just because of the manipulation. So that's something to keep in mind. With the gynecologic surgeries, especially when you're doing procedures with vaginal packing, you can get toxic shock syndrome. And remember, if you're keen on your gyn knowledge or your recent American history, when they use those super absorbent tampons that you could leave in for like a week or two. I mean, I don't know why a woman would want to do that. I'm not a woman, never had to use a tampon, but apparently it was appealing to some women to leave a tampon in for a week at a time. They developed toxic shock syndrome, and that was a big problem. So that's also a surgical complication with certain gynecologic surgeries. Oral surgeries, parotitis. Neurosurgeries, obviously meningitis, encephalitis. And then transplant surgeries, of course, you can get rejection syndrome. So these are all potential causes of post-operative fever, but very much depending on the surgery that you had. Obviously, you're not at risk for vaginal toxic shock syndrome if you had oral surgery. Orthopedic surgery, you can get gas gangrene, particularly this is going to depend on the nature of the patient's injury. Get into a car accident, dirty injury, gas gangrene is a possibility. Fat embolism is going to be patients with long bone surgeries, long bone injuries, like a clean fracture of the femur. And then patient-specific factors. So if the patient is adrenally insufficient, so a patient with Addison's syndrome, they can develop a post-operative fever if you don't give them extra steroids before the surgery. So this is a pearl of knowledge to remember for real life and for step 2 and 3. A patient who gets steroids for one reason or another, they're getting steroids every day, you need to give them more steroids before their surgery, because what are you doing when you're doing the surgery? You're putting a stress on them. So they're going to need more steroids. Now, patients who get steroids on a regular basis, they're going to have secondary adrenal insufficiency due to the fact that you're turning their ACTH secretion off. So you're going to need to give these patients extra steroids, and then patients with primary adrenal insufficiency, like due to Addison's disease, you're also going to need to give these patients additional steroids. So any patient with adrenal insufficiency prior to surgery, you need to give them steroids. If you don't, they will have adrenal insufficiency, go into an Addisonian crisis, and they can die. The things you can look for, in addition to the fever in patients who are having adrenal insufficiency after surgery, would of course be what you would look for in any patient who has adrenal insufficiency, which would be hyponatremia, hyperkalemia, low blood pressure. Cholecystitis is something that you see in very ill patients who are getting total parenteral nutrition. And this isn't just in post-surgical patients. I mean, we see it in post-surgical patients, but it's in anybody who's getting total parenteral nutrition. Patients who have parenteral nutrition are usually not getting nutrition through their mouth and their digestive tract. And when you turn your GI system off, it increases your risk of cholecystitis. And when you have cholecystitis, you get fever. So cholecystitis is something to keep in mind for very ill patients getting TPN. Gout, usually this is going to occur in patients with a history of gout. This can often be difficult to diagnose, differentially diagnose from septic knee. Usually when the gout happens in patients post-operatively, it's going to be in the lower extremity, but it can occur in the knee, it can occur in the toe, and so you can't just assume that it's a septic knee or that it's gout just because the patient has a red, warm, swollen knee or a red, warm, swollen toe. So you're going to need to aspirate and then give the patient colchicine if it's gout. Remember, if it's gout, you're going to see the crystals, negatively birefringent crystals. If it's septic knee, you're going to see the pus. ETOH withdrawal, alcohol withdrawal, this goes to any patient who is in the hospital who is an alcoholic, who abuses alcohol. Patients with history of alcoholism, you treat them with a benzodiazepine. Normally you use lorazepam or chlordiazepoxide. And what you see in alcohol withdrawal is tremulousness, hypertension, tachycardia, tachypnea. And so you're going to be generously giving these patients benzodiazepines. Usually we go with lorazepam. Chlordiazepam epoxide we give for patients in alcohol withdrawal on an outpatient basis. But on the USMLE, you will be given a list of choices, and there will only be one benzodiazepine. I can pretty much guarantee you. These patients should be sent to the ICU. So some clinical strategies. Regardless of when it happens, never ignore a fever. So even when it's in the first 24 hours. So if you had not watched these slides, you may have just assumed that a fever within the first 24 hours is just a normal reaction to surgery. And it often, usually, most of the time, overwhelmingly is a normal reaction to surgery. However, it isn't always. And when it isn't, it can be deadly. So you should never ignore a fever. First, you should consider the preoperative course. So were there any morbidities on presentation? What drugs is the patient on? You should read the operative notes. So remember, with infections, the duration of the surgery, longer surgery increases the risk of surgical site infections, wound infections. Were any blood products used? If you have any questions, you should not hesitate to speak directly to the surgeon, even though they might be tired and crabby. Nursing notes are always quintessential. How long was the Foley catheter in? Is it still in? The longer you have your indwelling catheter, the more likely you are to get a UTI, especially if you have it in longer than 2 days. That seems to be the magical point when UTIs dramatically go up. And of course, we're talking both men and women here because this is complicated UTIs. It's due to an introduction of bacteria from the outside. And then another thing, how often is or has the IV catheter been changed? Usually IV catheters are changed every 24 to 48 hours. I think at least every 48 hours. So make sure and look at the nursing notes. Make sure that the IV catheter has been changed because this is another common cause of postoperative fever. Most patients postoperatively have IV catheters in. But these should be replaced every so often. And IV catheter, we didn't really talk about this, but IV catheter causes of fever, you usually would see some kind of warmth infection around the site of insertion. And then also, has the patient been mobile? If they haven't been mobile, that's going to increase your suspicion for DVT, pulmonary embolism, thrombophlebitis. Are they using their incentive spirometer? Every post-surgical patient should have an incentive spirometer, especially if they're getting any kind of thoracic or abdominal surgery. Use of incentive spirometer reduces the risk of atelectasis and pneumonia. And only get labs based on reasonable suspicion. Obviously, we're all guilty of shooting off labs indiscriminately, but you should try to minimize the number of labs you get and just do them based on a reasonable suspicion rather than just shooting out 6 or 8 labs at a time.